My name is Dr. Melby. I'm an electrophysiologist at the Minneapolis Heart Institute, medical director of the electrophysiology lab, and it's my great pleasure to present ripple mapping in a variety of rhythms. It's an exciting technology which I think we'll find is very beneficial for mapping simple to complex arrhythmias. First of all, the basics of ripple mapping, to take a step back, this is a different method of displaying activation and local voltage than what we've seen before. The mechanisms of atrial tachycardia traditionally we know can be mapped out through local activation timing as well as through entrainment mapping. The local activation map does require precise annotation, which has always been one of the Achilles heels of this mapping method, is that no matter how long or fractionated the electrogram was, we had to choose one activation site to mark that. And this does require then precise annotation for all activation points, and critically, all activation depends on a window of interest that we set in a somewhat arbitrary way in many situations in order to determine early versus late. Entrainment has risks in and of itself. It's a very effective technique. However, entraining can terminate the tachycardia, can transform the tachycardia to alternate tachycardias, and within scar zones it can be remarkably difficult to capture and achieve active entrainment, accurate entrainment, in spite of this being the critical isthmus for termination. Now, ripple mapping uses a different technique that does not depend on mapping annotation whatsoever. What we see on ripple mapping is the entire electrogram displayed dynamically on the map. It's not necessary to annotate or review points of any kind, so once the map is complete, we can proceed with displaying the ripple map. There is no window of interest with ripple map as well, so two of the Achilles heels of traditional mapping are eliminated through this method of no marking of the electrograms and no window of interest to inaccurately mark early versus late. And this is an atrial tachycardia example. This was where the window of interest was set to default, minus 200 milliseconds to plus 200 milliseconds. Not an ideal window of interest setting, but it is oftentimes, as we know, the default setting in some labs. And looking at this map, we can see it's difficult to determine where is this atrial tachycardia originating from. There's no clear early activation sites. There's no clear late activation sites. All we're seeing is a sea of green. So based on this map alone, LAT mapping, it would be not possible to identify the source of tachycardia. Now, these same points that were acquired for the LAT map are now displayed as a ripple map, and you'll notice that ripple is displaying bars across the atrium. These bars are corresponding actively to the electrogram at that location, as well as sequentially they are moving. The ripple map does depend on using, in this case, a coronary sinus reference for timing. But there is no window of interest. This is playing multiple cycles of the tachycardia sequentially, one after the other. And now we can see clearly a wavefront moving across the atrium, demonstrating a left atrial roof-dependent mechanism. And we can see progressive propagation through this tachycardia from low to high across the septum towards the left atrial appendage. And we can see it coming over the roof towards the anterior left atrium as well. So with this, there was no window of interest set. There was no annotation of any points. These were the real data points, in essence, displayed dynamically. So this is this is an alternative way to display the map's bipolar data. It is a bipolar map, and it displays it as a propagation map. The point is not assigned just one time value. The entire sequence of the electrogram is displayed dynamically. In addition, we see there's a dynamic display of voltage. So this is the bar perpendicular to the surface. The larger the bar, the higher the voltage. And this gives us the ability to visualize all the complex electrograms that we had no method before of doing other than manually marking. That's a fractionated signal. It looks interesting. With this method, we can visualize double potentials. We can visualize fragmented potentials with great accuracy. And it combines all in one the three critical elements of mapping. It combines voltage, it combines propagation wavefront, as well as timing. And these three together have proven a remarkably effective way for mapping tachycardias. So I'm going to walk through then some basics on how Ripple displays these maps. And in this case, this is a map of a single point of activation marked here. This has a corresponding electrogram, which is 1112 on the intracardiac signals below. And we'll see that the 1112 electrogram is a fairly standard electrogram with a tiny R wave, a large S wave, a large R prime wave, and then back to baseline. Now when we play this map through with Ripple, what we should see is we'll get a small ripple, a big ripple, followed by a big ripple, and then back to baseline. So again, small ripple, big ripple, back to baseline. So all elements of the electrogram are displayed dynamically, and we can see how this corresponds to the intracardiac electrogram. This is an example of a complex fractionated signal. We can see multiple components at this signal, and it's marked on the carto map here. The signal, as you can see, is highly fractionated, multi-component, and traditionally we would have to select one annotation to this electrogram. Now with Ripple, we can play this in real time, and it will display all of these components, and we should see several small ripples which are building to larger ripples as the voltage increases and then returning back to baseline. You see several small ripples, two large ripples, and then back to baseline. Several small ripples, two big ripples, back to baseline. So this is showing all elements of that complex signal. We no longer have to be limited by single point annotation, and it's remarkably helpful in scarred or zones of slow conduction. Now when we put all this together in a sequence, this is an example of a sequence of points that were obtained across the anterior left atrium, one after the other. And the intracardiac electrograms are displayed corresponding to those points. And we can see a sequence of activation occurs through those points. And as we play this ripple map, you'll see it displays this as a propagation. So every time a point is noted at the activation, we can watch the ripple proceed through in sequence, almost like we're looking at a propagation map, but in many ways giving us additional information about the fractionated components as well as the voltage. So this can show then in simple format what the propagation maps look like and how they can be transferred to the ripple map. So once this is complete, then in these complex rhythms, we can display ripple map as an active propagation map with all of the data that we've discussed. In many ways, I think of the ripple map as presenting the real data. These are the real electrograms. Nothing is filtered or processed in any way. So this can be quite helpful in eliminating some of the artifacts that occur by artificially annotating or setting windows of interest. And the map displays then in sequence exactly how this tachycardia is proceeding. We can see the wavefront break down the septum and lateral portion of the mitral valve annulus in great detail. We can see these, much of the detail that was hard to see in other ways. So my experience so far with Ripple, I've done 135 cases performed from when it first was released in November of 2016 to present. This has involved mostly atrial tachycardias. 96% have been atrial tachycardias, but of all sorts. Atypical scar-mediated atrial tachycardias, post-AFib ablation atrial tachycardias, scarred atrium, congenital heart disease, mapping both paroxysmal AFib and persistent AFib. All of that has proven remarkably effective. For ventricular, I performed mapping with Ripple in idiopathic VTs as well as scar-mediated VTs, and found it to have utility in all of these maps. And in those cases, Ripple mapping accurately identified the critical tachycardia isthmus in 98% of these maps, both in the ventricular and atrial side of the mapping. And I found in my experience that Ripple mapping often revealed critical facets of the tachycardia that were otherwise very difficult to appreciate, particularly zones of slow conduction within scar, figure of 8 tachycardia has become much more easily visualized with this method. All of these elements that were a key to ablating simple to complex rhythms are displayed actively. And it's most beneficial, particularly in atrium, which are fairly scarred, multiple zones of slow conduction, where LAT maps oftentimes would mark late activation as early because of the constraints of the window of interest. So tachycardias involving scar, reentrant rhythms, and atrial ventricular substrates that have slower late conduction. This has proven much more effective than traditional mapping methods. So I'm going to start by showing a case that I performed. A 79-year-old female. She had a past history of TIA in 2014 and hypertension. She developed paroxysmal atrial fibrillation in 2013, which initially was treated with sotalol at low dose and increasing to medium dose. Unfortunately, she continued to have symptomatic atrial fibrillation, and she underwent a PV isolation procedure in 2016 at an outside institution. They utilized a wide area circumferential approach for the pulmonary vein isolation. They did document entrance and exit block during that procedure, a reasonable endpoint and result. Unfortunately, post-procedure, she developed an incessant and highly symptomatic atrial tachycardia. She was amiodarone initiated and loaded. Cardioversion was performed on 2 occasions, but unfortunately, she reverted back to sustained atrial tachycardia within 48 hours of the cardioversion, and she was referred for an ablation procedure. This is the presenting electrocardiogram demonstrating that this does have an atypical appearance, not a typical atrial flutter appearance, as buried within the T waves is a positive P wave located in leads 2, 3, and AVF. And it also looks suspicious to be positive in V1 through V6 leads, all consistent with atypical, probably left atrial origin. The intracardiac signals of the presenting rhythm by coronary sinus are displayed here, and this is displayed as a proximal to distal coronary sinus activation. And there is concentric activation within the coronary sinus, indicating probable left atrial origin. The mapping methods are outlined here. Confidence was used with Pentre, which is critical for mapping these complex tachycardias. Maximum density for point acquisition, the stability, catheter stability was 3 millimeters. The cycle length filter was set at plus or minus 5% of the tachycardia cycle length. Again, the mapping was performed with a Pentre catheter, which is critical for these cases. I do use also a decanav catheter in the coronary sinus, and just to highlight a little bit about why I use the decanav in the coronary sinus is that the catheter has a magnetic sensor. This allows for very minimal use of fluoro for inserting the coronary sinus catheter, and as we move towards reducing fluoro overall for the case, eliminating 30 seconds or a minute or longer of fluoro on the CS catheter insertion, I find it to be quite helpful. In addition, and equally important, is that the decanav catheter has an IVC electrode on it. It's one of the few catheters that does have an IVC electrode. And the IVC electrode is very important for obtaining accurate confidence maps. Confidence maps depend on unipolar electrograms, and these, using the standard Wilson common terminal, are oftentimes very noisy. So using an IVC electrode reduces significantly the extent of unipolar noise and improves the accuracy of the confidence map. The other modules that I use actively with the Cardo 3 system are listed here, including Cardo Sound. Confidence for all maps is performed. Visitag I use for marking all ablation sites. Ripple mapping, of course. I do use Cardo Cafe on occasion. Passo is also loaded. Cardo Smart Touch catheter, Cardo Replay, and Cardo Merge. The ablation catheter in this case was a Smart Touch SF catheter. Here's an example of mapping of this tachycardia with the Pentre and using confidence. And you can see it very rapidly and automatically is annotating these points. And within 5 to at most 10 minutes, we can have a map of several thousand activation sites. And you can see in this case, it's 2,500 activation points over the course of about 5 minutes. And you can see how it is rapidly and actively updating with activation points. Now, following that, this is a display of the LAT map of this particular tachycardia. This window of interest was set at -100, the tachycardia cycle length, to 0% of the cycle length. And as you can see, it's a very confusing LAT activation map, as many of these post-AFib ablation tachycardias are. It's showing early activation from the right superior pulmonary vein. It's showing early activation from the left inferior pulmonary vein. And based on this, it's not possible to accurately identify where the atrial tachycardia is originating. Setting this to, as many folks use, a plus or minus 50% of the tachycardia cycle length with the window of interest. This is helpful to some degree. It's indicating perhaps an early activation in that left pulmonary vein antrum. But nevertheless, it's a confusing map, as we've got late activation and early coming from this left inferior pulmonary vein. And again, I don't think we could accurately pinpoint precisely where this tachycardia is originating from. If we turn now to the propagation map of this data set, we can see again a confusing propagation map of showing activation from the bilateral pulmonary veins. We can see, though, that it is activating from high to low across the posterior left atrium. And as we rotate, we can also appreciate that based on the propagation map, that it is activating over the roof of the left atrium, across the anterior left atrium, and down the septum. So we can, as always with these maps, obtain some useful information. We know it is activating high to low across the posterior wall. It's moving across the anterior from, again, high to low. But we can't localize precisely in any way the origin of this tachycardia. Now, using Ripple map, this is displaying the same tachycardia that we were just looking at. And Ripple, again, is confirming activation across the roof and down the anterior left atrium and the septum. It emerges out and breaks to the appendage as is visualized. Then I want to illustrate that we have activation after it moves across the anterior left atrium. It enters the right pulmonary veins in front of the right. It enters then the right superior pulmonary vein and then to the right inferior pulmonary vein. So we can see probable entry and breakthrough of the previous ablation lines to the right superior first and then to the right inferior. So we now know that the right pulmonary veins are not early as some of the LAT maps had indicated. These are actually late. The other point I'd like to bring out is that you can see across the map flickers of ripples occurring. And this is just low-level noise from catheter movement or catheter banging. It's a random noise, and you think of that as, well, when I'm looking at an electrogram, I do see random baseline noise as well. Well, this is demonstrating that visually. But even in spite of that noise, we can see clearly a wavefront progressing in a fashion that we can understand. And this then is proving remarkably effective at demonstrating what is happening to the right pulmonary veins. And when we look posterior, we can see better as to the true origin of this tachycardia. First of all, if we take a step back, we're also seeing activation from high to low across the posterior left atrium. We again see activation into the right superior, finishing in the right inferior pulmonary vein. But I'm going to draw your attention to a corridor of conduction that Ripple has identified from this left inferior pulmonary vein. And if you can appreciate that there is an initial rippling within that left inferior pulmonary vein, it moves through the corridor and then breaks out to the roof of the left atrium, indicating why it's moving from high to low across both the anterior and posterior left atrium. But the true origin is a focal tachycardia from that left inferior pulmonary vein, and moving through a long stretch of corridor, a remarkable stretch of corridor, because of the prior ablation. Based on this, there must be a line of conduction block, which is illustrated by double lines in this video, a line of conduction block from the prior PV isolation procedure, but that allows for this remarkable tachycardia emerging centimeters away from its origin, one that would be quite difficult to appreciate in other ways. So once that critical site was identified, this is RF application number 1. RF is turned on, and within moments we have tachycardia termination at the successful site. indicating clearly we had an accurate map. And this is the corresponding tags to where that ablation was performed. Again, right in the zone where Ripple identified early activation. A second case I'd like to go to now is a 75-year-old male who had presented with symptomatic and highly symptomatic persistent atrial fibrillation in 2012. He was treated with a series of antiarrhythmic medications, including flecainide, Ticastin, and then amiodarone until persistent recurrence in 2014. At that time, he underwent an AF ablation procedure, and at that point, wide area circumferential PV antrum isolation was demonstrated and performed. During ablation, the AF converted to a left atrial roof flutter and then to a mitral flutter, both of which were successfully ablated with demonstration of conduction block across those lines. In addition, PV entrance block was documented at the end of the procedure, and he did quite well. He had no further recurrence of atrial tachycardia until 2016 when he presented with sustained and symptomatic atrial tachycardia. This is the baseline electrocardiogram of that tachycardia, demonstrating very low amplitude P waves with a relatively long tachycardia cycle length. This as well appears to be clearly an atypical atrial tachycardia, not consistent with cavo-tricuspid isthmus-dependent flutter. The presenting coronary sinus activation is demonstrated here, and this shows a fairly concentric coronary sinus activation. There may be slight proximal to distal preference, but it is consistent with left atrial origin predominantly. So again, the procedure methods for mapping, this was a case performed with the Pentre and Confidence. The module settings, once again, maximum density, the position stability was at 3 millimeters, and the tachycardia cycle length filter was set at plus or minus 5%. Again, DECA-NAV was used for coronary sinus, and the CARTA-3 system modules are listed here, which were used in conjunction with this mapping case. The ablation catheter was once again a SmartTouch SF catheter. The initial procedure was a standard LAT map. Again, the window of interest is set at minus the 100% of the tachycardia cycle length to 0. And this is demonstrating that we, unlike the first case, we do have some elements of an accurate, reasonable LAT map. We are seeing activation across from high to low across the anterior left atrium and down the septum. We can also see some elements of low to high activation on the posterior wall. And I'll switch views. Now we can see an RAO versus a PA view. And this once again is demonstrating low to high activation on the posterior left atrium, high to low activation across the anterior and the left atrial septum. All of this consistent with a left atrial macro reentrant flutter, roof dependent, as we have the 100% of our tachycardia cycle length, and we have a consistent activation pattern. You'll note, though, that as oftentimes the LAT does have artifacts which are inaccurate and due to interpolation between points. One example is across the septum where there's a band of supposedly reversed conduction, this green-yellow band, which is an inaccurate representation. And there's also at the floor this inaccurate green-yellow band, which would suggest that there's a reversal in activation when there it truly is not. The reasoning behind some of the difficulties with LAT is that the interpolation here is occurring inferior because there's a band of no points being demonstrated, and across the septum there's a scar points which are being inaccurately interpolated. So common scenarios with mapping, we never have perfect maps with every site covered. The propagation map now is displayed here, and this once again is supporting conduction across high to low. We're moving across the posterior left atrium from low to high, and it is crossing the left atrial roof. This is consistent with the left atrial roof-dependent macro reentrant flutter. Now, examining, though, the propagation, we can see that it suggests that activation is broadly across the left atrial roof without any critical isthmus. And based on this, we would be contemplating an ablation line across the entire left atrial roof. And this would be the standard practice. Now, This turned out not to be the case, though. There was a critical isthmus present on this left atrial roof, and the only way for us to have known that was through ripple mapping. This is the ripple map of the posterior view, indicating in combination with the bipolar map, and I do find that that combination is remarkably helpful to display both the bipolar voltage along with the ripple map to truly understand these circuits. And if we focus now on what's occurring, yes, it is confirming what we saw before, activation down the anterior left atrium. There is a critical site, though. We can see the roof is fairly low voltage. The scale of voltage here is 0.06 millivolts. But within that zone of low voltage, we can see a clear breakout of this atrial flutter located right here at the anterior portion of that line. And if we look closely, there is very slow conduction, very low amplitude rippling that is moving through this channel that is outlined through these double lines and then breaking out to the rest of the anterior portion of the left atrium. So we do actually have, unlike the propagation map suggestion, we do have a critical isthmus that is located at that anterior part of the left atrium. So once with that particular knowledge, we proceeded with ablation, and here again is our RF application number 1. Ablation is turned on, and within moments we have termination to sinus rhythm of that atrial flutter, clearly again indicating that we had a small critical isthmus of that left atrial roof. And these are the corresponding ablations that were performed that correspond with the ablation demonstrated in the past figure. So very effective method for determining precisely where it is at, and it's certainly saved a fair amount of procedure time to identify that site up front. Looking back at some of these inaccuracies that were demonstrated on the LAT map with these bands across the left atrium, clearly with the ripple map we had none of that difficulty. The ripple played as a propagation through those zones and didn't have any difficulty with identifying those accurately, those wavefronts. The third case I'd like to present is some fascinating research that I've been working on in terms of mapping atrial fibrillation with ripple. This is a case of a 69-year-old female who had no standard risk factors for atrial fibrillation. She had no coronary artery disease as well, but no hypertension, obesity, sleep apnea, or diabetes. She had presented in 2013 with paroxysmal atrial fibrillation, which was treated initially medically with flecainide at escalating doses. She had good control of her atrial fibrillation until 2016, at which time she re-presented with recurrent highly symptomatic atrial fibrillation, and we proceeded with EP study and AF ablation. On arrival the day of the procedure, she was in atrial fibrillation, which allowed for mapping in ripple with atrial fibrillation. For AF mapping, the procedure methods are outlined here. The confidence, again, with Pentarray is key to mapping these particular rhythms, all of them. The module settings, again, maximum density to increase point coverage, stability catheter at 3 millimeters. The reference cannot be an internal coronary sinus reference, as this is atrial fibrillation, so surface lead 2 or any of the surface leads would be adequate for mapping and use with confidence. The ablation catheter in this case was Thermocool Smart Touch. The other modules outlined here were used during the case as well. This is the presenting map, and as you can see, within minutes, this took less than 5 or 10 minutes to achieve. We've got a map of almost 5,000 points, and here's the baseline voltage with the scale set at 0.1 millivolts to 0.5 millivolts, and we can see that this appears to be a highly scarred atrium. There's patchy scar across the posterior left atrium, across the floor, all across the roof and the anterior septal left atrium. Clearly not a high voltage atrium, indicating oftentimes that there may be other non-pulmonary vein sources for atrial fibrillation based on this substrate map alone. Next, I'd like to show the ripple map as it's playing, and in order to display active AFib, I play ripple at the slowest speed, which is a setting of 1. And this, if you look at these ripples, this is dynamically showing atrial fibrillation as mapped with the ripples corresponding to the intracardiac electrograms. I'd like to characterize regions as high ripple frequency, which are indicating active potential AF driver sites. And in particular, we see very fast rippling occurring in the posterior aspect of the left pulmonary vein antrum. We also see fast rippling across the posterior portion of the right pulmonary vein antrum and extending a little bit onto the posterior wall. In comparison, if we look at an AP view, the ripple site on the left pulmonary vein antrum is significantly rippling with higher frequency compared to the anterior left atrium, indicating that probably the AF driver is located within the pulmonary veins at this time rather than the anterior left atrium. So evaluating these types of maps depends on comparing between regions of the left atrium, which is rippling fastest, which is rippling slowest. And for the first time, we can get a global look at atrial fibrillation to see what sites have the potential for driving this. But as we all do, I proceeded with PV antrum isolation, particularly given that we had probable AF drivers noted within the pulmonary veins. And sure enough, with pulmonary vein antrum isolation, the atrial fibrillation terminated to sinus rhythm. And that looked like a good result, and I thought, well, perhaps that would be sufficient. And the results look good based on the bipolar map. A high-density confidence map post-ablation is showing nice pulmonary vein antrum isolation. The visit tags are shown here that correspond to the ablations that were performed that terminated this atrial fibrillation. Unfortunately, with basic coronary sinus pacing at 290 milliseconds, sustained atrial fibrillation was easily reinduced, and this is an indicator for higher chance of recurrence of atrial fibrillation. So seeing that, I proceeded to remap this atrial fibrillation with ripple, and that is shown here. And now clearly we can see very slow rippling across the entire posterior and floor of the left atrium. In comparison, we see much faster rippling across the septum and anterior left atrium. So we have a gradient of rippling, and this is indicating a probable AF driver, possible AF rotor located on that high posterior septum and into the anterior left atrium. So I proceeded to perform ablation across that high-frequency ripple zone, and sure enough, this re-terminated atrial fibrillation back to sinus rhythm. These are the corresponding visit tags that were performed. The termination occurred predominantly at the high septal site. I did extend the ablation to cover the left atrial roof and achieve conduction block across that structure. But now, once that was complete, rapid pacing down to 200 milliseconds failed to reinduce atrial fibrillation. So this is a good example of where we can actively use ripple not only for mapping of atrial tachycardias, atrial flutters, but also mapping for AF drivers, and it's proven quite effective in that regard. So in closing, I'd like to highlight that the value of ripple I found through using it in these cases, it's proven remarkably effective and a much better tool for mapping standard tachycardias, far better than LET mapping, entrainment mapping, propagation mapping, all of which are an excellent method, but have fundamental flaws which oftentimes show up in both simple as well as complex tachycardias. Unlike that, ripple is showing us real data. It's showing us really what the activation is truly occurring. Every element of the electrogram is displayed. None of it is filtered or annotated in any way. In addition, I find there's a great benefit to not having to set a window of interest or to annotate any points whatsoever. Once the map is complete and I have several thousand activation points, we can play the ripple map and identify the critical structures in combination with the bipolar map. It's proven remarkably effective.